Welcome to Health Law Talk, presented by Shahardy Sherman Williams. Health law broken down through expert discussion, real client issues, and real-life experiences. Breaking barriers to understanding complex healthcare issues is our job.
And good morning, good afternoon, whenever you're listening. This is another edition of Health Law Talk here at Shahardy Sherman Williams. Conrad Meyer, Rory Bellina, healthcare attorneys, bringing you the latest and greatest in healthcare law, policy, social issues, right? Is that right, Larry?
That's right. Good description.
And today we have a guest in the studio, the wonderful Dr. Aries Christakis. Dr. Christakis, how are you?
Good. Good morning. Thank you for having me today.
Yeah, thanks for coming.
We really appreciate that. Now, I knew you listened to the show. You told me you listened to the show, and we're very appreciative of that. So now that you're in the studio, like you're sitting here, what do you think? I mean, I'm putting you.
I think it's a very nice setup. I think it's it kind of all makes sense because your audio sounds really good on the podcast.
We appreciate that.
And you have a real professional and legitimate setup here.
Well, we tried.
Thank you. Yeah.
We tried. Now,
A labor of love, but we've got it set up.
Rory did all the building. I mean, he was the one that put all the stuff up.
It took a little bit of time, but we've got it now, and we're happy with the results. So
I think the result's good. I think that's good. And we thank you for coming in. So general surgeon, what tell me about you. We know you're a physician. I know you're a surgeon. I don't know much. I'd like to know more about you. So how did this start for you? How did your journey start, med school, and to where you are now? How did it all begin?
So I wouldn't say it was by design, but sort of a New Orleans person. I've done high school, college, med school, residency, and now work all within a few miles radius.
All here, like in Louisiana?
In New Orleans.
wow.
Oh, wow.
Which is, a little bit unusual with a brief hiatus where I was in Alexandria after residency doing some trauma surgery. But, medical school is one of those things. You're in college, like the sciences, feel like you like interacting with people, hearing people's stories, working with people, and, of course, helping them. And medical school becomes sort of a natural attraction. Then I have a memory in medical school enjoying the emergency room, which is what I thought I wanted to do. And then I saw people getting wheeled out of the emergency room to go to the operating room. And I felt like that's where the real fun was.
Like, where are they going? They're going somewhere else.
And there's really some fantastic things that happen in operating rooms, whether by general surgeons or other surgeons. And sometimes the collaborations that work over there are really, the collaborations at work are really fantastic.
Well, how does that work? I mean, let me ask you that. So, we always hear cardiac surgeons, neurosurgeon, orthopedic surgeons. How does general surgery fit into the layers of specialties? How does that work in the surgery area?
So, traditionally, they were just surgeons. Back in the day, that was sort of where they started, and it was just a surgeon, and they did everything. And they slowly started to subspecialize, and you've reached a point where there are, for residency training, there's multiple different training tracks. There are a fair number of them that start with general surgery, and then they will complete the rest of their training elsewhere. Maybe they'll just do 1 year of general surgery, maybe they'll do 2 or 3 years, and they'll complete their training in
whatever subspecialty they decide.
Yes. Oftentimes, they have to complete an entire surgery residency to go and do that, but that's one of those things that's changing.
Is it a 4-year, 6-year? What's the common for general?
General surgery is 5 years.
5, okay.
And just to use, say, vascular surgery as an example, there are many programs that are 3 years after a 5-year general surgery residency, but there are also what they call 0-5 programs, which are vascular surgery from the beginning, and they don't do a full general surgery residency before going on to do vascular.
So on match day, you can literally match in a 3 or a vascular surgery residency from the beginning.
Yes.
Wow. Okay, I did not know that.
That's relatively new, and if I have, this is all current as of the last time I was a resident and had these conversations. So
gotcha.
If it's no longer 05, but I believe that's what it is.
So you can go. So some programs, like meaning another professional boards, like vascular or cardiac or whatever. So you can go to a general surgery residency for X number of years, and then sort of apply. Is it considered a residency, or is that considered a fellowship?
A fellowship.
So it's a fellowship.
Yes.
And it's dictated the years by whatever that professional board is, right? Or is there some other way, some other governing body that says, hey, this is what you do for this?
Yes, there are some. So trauma surgery, for example, has a 1-year fellowship, which in some locations is a 2-year fellowship. And so there is some variability amongst the fellowships, but there are a lot that have a minimum requirement.
Interesting. So you went straight into general surgery, 5-year residency, and then what happened next? You just go straight to practicing?
So I had spent 5 years doing my residency here at LSU in New Orleans. Mm-hmm. After residency, there was a plan for me to stay with one of the local universities as staff.
Okay.
And for various budget reasons, they weren't able to make that happen in the end, to make their vision happen.
Okay.
And so I ended up at that point going to Alexandria, Louisiana to do trauma surgery. Trauma surgery is one of those things that doesn't necessarily require a fellowship if you've had the experience and know what you're doing. Mm-hmm. And I worked 3 years up there at Rapides Regional Medical Center, which is, a very good level 2 trauma center. Really a fantastic place, gives people great care. And we did a lot of good things up there.
Now, were you with a group up there, or you worked for the hospital itself?
We were hospital employed.
Gotcha. Okay.
And I was there for 3 years and came down here. And I'm currently hospital employed over at Turo, where I'm a part of their general surgery program.
Gotcha. So so you straight from Rapides back home and at Turo, and have been at Turo ever since. Yes.
And so here, of course, not doing trauma surgery at Turo, doing more general surgery and acute care surgery.
Very interesting. Very interesting. So let me ask you this. It's got to be, it's a lot of pressure to be a surgeon, I would think. I mean, you're talking, to do surgery on someone, patient comes in. I know lawyers have pressure, but I don't think lawyers have pressure, Rory, the way surgeons would have pressure,
No, I think, like Conrad mentioned, I'm sure that the pressure that you have is life or death. Ours is not, and then obviously you've got to.
We lose a case or
sure.
we don't do a deal, right?
Sure. There's a time component, and it's doing it proper. If Conrad or I mess up on amending bylaws, we could re-amend them.
Right.
But if you mess up on a surgery, there's a lot more significant repercussions for the patient. So I guess if you could talk about, you said that. You thought you wanted to do ER work, but then seeing the patients leave the ER and come in and or go off to surgery led you to surgery. Was that what kind of drove you to go that path? Is like the excitement of getting in there and fixing it, as opposed to just kind of treating and referring out, or was it something else?
I think there was, for me, a part of the attraction was being able to see through the entire issue. From start to finish. And, that was something that, the emergency room does a lot of fantastic things, and they know enough about everything to sort of manage all of the acute things. But I think not being able to be there for the definitive management and see how it turns out was not something that I was crazy about. And I think they do fantastic work, and they're a huge asset to us. But spending time in the operating room, fixing the problem, seeing it through, is something that I found attractive. And surgery is somewhat unique because you more often have an opportunity to definitively fix a problem. Obviously, it's not always that way, but it's not, for example, like blood pressure, where you will treat someone's blood pressure and you will probably treat that for their entire life, and you will sort of manage it. there's more opportunity to definitively, excise a tumor or remove an inflamed appendix.
Right.
Or, definitively fix something. And a lot of our patients are not our lifelong patients for that reason.
That's it. I mean, so when you get in, you can actually see. Now, let me ask you, that's a good question. So when you ever gotten into a surgery before and you're like, oh, I know what I'm going after, and then you went in and you're like, wait a minute, I found something else. I need to fix that. Is that, and then it's like an aha moment, or you thought one thing and you got in, oh, well, this is really the issue. Has that ever happened before?
It's pretty unusual. I think that with imaging these days and our aversion to surprises in the operating room.
Yeah, that would not be good.
When I have a case scheduled, for example, tomorrow I have 5 cases scheduled tomorrow. And
oh, wow.
I can sit down and sort of run through every case in my head, and I can visualize the entire case. And that's sort of the tendency. And you have all of the imaging, and you really leave no stone unturned before you go to the operating room.
So you've already done it. Like, in other words, in your mind, you have gone from, prep to close in your mind of that case before. Wow.
Yes. And I don't know if everybody does it that way, but in my mind.
But that's how you do it.
Yes.
And that's right. And that's very methodical, because you have to be perfect the whole time. I mean, it's hard, and that's what I was saying with Rory. I mean, we can mess up, and we can kind of fix it, right? We can do things, change things, amend things. I mean, and I tell this to students, because I teach the law students, and I try telling them the mentality of physicians. I mean, you have to be perfect 100% of the time. That's kind of a high bar, Rory? I mean, that's a high bar.
Yeah. I had a question for you, because Connor and I were talking before the show about a future episode we're going to do with reps, device reps, or whoever it may be. I want to get your perspective on how you've seen, like in your years of surgery, how you've seen reps evolve. Do you have a lot of experience with them? Are they in surgery with you, just sitting there guiding, assisting, and kind of what's your overall opinion of them? Because there's been a lot of controversy regarding reps in the surgery room, obviously how they're paid and how they can and can't be paid, and then just overall what your relationship is with reps in the OR suite.
So reps work pretty closely with us pretty often. I think that in my practice, I don't see a lot of reps on a daily basis. They will occasionally poke their head into a case of mine and check that everything's okay and I don't have any issues. For example, there's a rep who provides one of the mesh products that I like, and I've been using that same mesh product since sometime in the middle of residency, and he is the same rep that's been coming around. And so there's not necessarily anything new to show me with those products. Every now and then there's a new product that comes out and they have something to show you. But they'll poke their head in and make sure that everything's situated. I do think that in some of the subspecialties where they're using, sometimes they might be using some fancier equipment, there is close collaboration that I think is important. I think the big thing that I had spent some time with reps was with the Da Vinci robotic system. When I first started doing robotics, I've lost count, but it was probably a few years ago now. They have a whole onboarding process to make sure that everybody's getting the appropriate skills and that sort of thing.
Da Vinci does that?
Yes, they have a program.
I was going to talk about that, by the way. I was going to get, but you got to it before I did. So I'd like to hear a little bit about what's that process like and the onboarding.
So, for general surgery, Da Vinci has a huge piece of the market share. I know that other robots exist, but just to give you an idea, I've never seen them. I've read about them. I know of at least one in town that they've sort of experimented with, but they really have the vast majority of the market share for general surgery. And so what they will do is, this is all for procedures that you already are familiar with,
right?
And you're already presumably doing them open. A lot of them, you've been doing them laparoscopically for a long time, so you've been doing the minimally invasive already, and sort of the robotics is adding a different instrument, at least in this case for the general surgeons. And so they have a program where they will take you to one of their facilities. I know there's one in Atlanta, maybe there's one in Houston, and they will take you there for sort of an intensive course. They will have a cadaver lab or a lab that uses that will use pigs as the subject and sort of teaching skills. And once that is done, they will assist in getting you a proctor at the facility that you work at. So somebody will come to your facility and sort of make sure that you don't have any questions as you're getting acclimated with the robot.
I have a basic question about robotics. So if I come see you at Toro, or if I'm referred to you for surgery, and you say, Rory, I want to do X surgery, does the patient have any choice in whether it's going to be done through robotic or not? And what are kind of are there any advantages, disadvantages? And then obviously from a reimbursement standpoint, if you could talk about that on kind of the differences between, I guess, doing it the old school way versus robotic.
So taking reimbursement first, the open procedures get reimbursed different than the laparoscopic procedures. So laparoscopic being the minimally invasive. And the robotic procedures, I think that the term they often prefer, if you're looking for a more precise term, is robot-assisted laparoscopic surgery.
Okay.
And so for those procedures, at least in general surgery, they almost universally reimburse the same as the laparoscopic. So once you're minimally invasive, those reimburse the same.
Okay. Well, there has to be a huge cost to getting these robots to the hospital. So can you talk about some of the benefits or some of the reasons why you choose not to do one for a patient?
So in my practice, I think that there are certain procedures that have significant advantages in doing them robotically. For me, I think there are advantages for hernias, for colon surgery. Those are the two big ones, and there are a lot of different permutations of that. I get a little less excited about it for gallbladder surgery. I think that there are a lot of people out there that will do them robotically, and I think that that's a very reasonable way to do it, and there are some advantages. But for me, the cost benefit's not entirely there in my hands. And so for that reason, I don't necessarily recommend it for that. I do think, patients do get some choice. If a patient comes to me, for example, and they want an inguinal hernia repair, I can talk to them about doing it open, doing it laparoscopically, or doing it robotically. Usually when we have that conversation, I think that the benefits for and robotic-assisted inguinal hernia repair are stark enough that they will usually choose that.
Okay.
It's interesting because I think just people, not like Dr. Christakis here, or just like even you and I, Rory, because we do this a lot every day, but the general public, here's robotics, and they're like, I want to get that, So if you just literally put the word robotic, right, or robotic surgery, they're going to come and say, well, if I have the surgery, I want the robot. Because they think in their mind, it's like, oh, it's better.
And I will say that this is not something that's limited to lay people. I had a physician that came and saw me in clinic last week. Mm-hmm. He had an umbilical hernia that needs repairing. It's not very big. It's of a size that doesn't require mesh. And really doing it robotically, on the whole, will give him, in aggregate, longer incision, potentially a little bit more pain, and really no benefit.
There's no benefit.
And that's a case where even a physician will come in and say, I'd like this to get done robotically, and it's our job to sort of educate the patient to where they are thinking about the same things we're thinking about, they're worried about the same things we're worried about, and looking at the same benefits that we're looking at. And, they usually will follow the recommendation.
But I mean, do you have patients that come in and say, you know what, I heard you did robots, and I really want you to do the robots because I want to get robotic surgery because that's the best. I mean, do you have patients that do that and say, oh, I got to have the robot?
We do, and to be honest with you, most of the time they're right.
Oh, at least they're right. That's good.
I think that
I'm just if I'm a surgeon, I'm like, you know what? I'm just going to put the sign robotic, and then people are going to want to come see me. I think that might work.
Yeah.
For one example is that anytime I'm placing mesh, I prefer to place it robotically. I think that mesh has sort of been a hot topic in the legal world, and so. Enough to where, you have these advertisements on TV, and so it's in patients' minds, and, they have concerns about it. And really, whenever we're doing a hernia, there's two things that we're looking for. One is to make sure that it doesn't recur, and two, to make sure that we don't get an infection. And I think that there was a very big jump in decreasing infection rates when we went from open surgery to laparoscopic. And I think that there's some further improvement going from laparoscopic to robotic, in addition to some of the other benefits of the actual repair and being a better repair. So to be honest with you, most of the time, patients have that right. I do think that there are distinct advantages.
You mentioned pain, and we have an episode scheduled with a pain physician, so I won't go too deep into this, but I'd love to get your history on how your practice has changed for pain management post-surgery, because you mentioned mesh and now we're talking pain. If you could just talk about what you learned in med school and residency regarding pain and pain management and the opioids, and then just in practicality issues you've run into, issues with patients, and then kind of how you handle it now, because it's a very controversial topic, and I know the CDC or the FDA recently, as recent as this week, I think, has revised some guidance on how pain management should be done post-surgery. So
this is a very interesting topic. I mean, we're wading in some waters here, but I understand where you're going with this. It's like a mosaic picture.
So
it's fluid.
So you're kind of forcing me to use the tired metaphor of the pendulum.
Sure.
Yes.
So when I was a resident, I have a distinct memory, so we were a trauma center, and I have a distinct memory of there was a nurse that would come around that was involved with pain, and they would come around and sort of critique the amount of pain medication we were prescribing. And they, are sort of following the data that's there at the time. A lot of this data and how this data came about has sort of been in the news a good bit lately. But it was very common for them to tell us that we were not prescribing enough pain medication. And, they would sort of push you to prescribe more. And some of us were a little bit more stubborn than others and, kind of holding our ground and saying, well, that's what I feel comfortable prescribing. We're not going to do more. And then I have a memory at some point after residency when they started telling us that we were prescribing too much pain medication. All the while, when I was prescribing too little and when I was prescribing too much, I was always prescribing the same.
Sure.
And I think that now they're starting to come back the other direction and realize that maybe it was a little bit of an overreaction, the way they handled, they cast a little too wide of a net in trying to rein in some of the opioid usage, and it was sort of affecting some of the surgical patients and that sort of thing.
Sure, because it's needed for a lot of your surgeries. I mean, I'm sure I've undergone a couple of surgeries and been prescribed them. I'm sure most of us have. It's needed for real pain for a lot of surgical procedures, but then you have the issue of addiction or abuse, and then chronic pain, which is a totally separate topic. But I think for you and for surgery, it is needed for some. And if you could just talk on that, on your experiences with that.
Well, I will say that, one thing that has come out of all of this is that there is a lot of healthy conversation around the usage of pain medication, and it's not something that's just done lightly and taken for granted. And so, when in surgery, we don't expect patients to have chronic pain. It's very rare for us to have a patient who postoperatively has chronic pain. And when they get into if they get into an area where they're having chronic pain, that's not something that's really best managed by a general surgeon. And so that's a patient that you would refer out to a pain clinic or someone who does
if you can
pain
find
medicine.
one. If you can find one now.
But, that's something that's very unusual for us. For us, usually the pain is a conversation with the patient for after surgery. And, to be honest with you, what I'll tell the patient is that, I don't want you to be uncomfortable.
Mm-hmm.
I don't want this experience to be miserable for you. But do know that your pain is, to a certain extent, it's temporary and it's kind of secondary to the primary goal, which is to have your problem fixed definitively, without other complications. And the pain we can manage in the short, 7 to 10 days that's an issue.
If you had to, I'm going to pivot for 1 second. So if you had to, I'm sure you get this. Family comes up to you, maybe one of your friends, and they said, my son or my daughter wants to be a surgeon. Can they come talk to you? We get it too sometimes with lawyers sometimes, and they ask if you want to go to law school. I say, no, don't go. But I wanted to ask you from a surgeon, when you get people that ask you, my son, my daughter wants to go to med school, and they really want to do this, and they want to come talk to you. What do you think about that in today's climate, in today's provider client, culture, client, payer, all the regulations, all the stuff you deal with every day, the schooling, the work? What would you tell someone in terms of if they wanted to be a physician? How would you respond to that? When you don't want to crush a kid's dreams and all, and you might want to go to that. But I'm curious, how do you respond today? If someone says, "Hey, I want to be a doctor," what do you tell them?
So,
did I throw a curveball at you? Huh?
No. I think that it's a good question because it's true. There's a
lot going on today.
Cost of education going up, reimbursements going down.
Right.
There's a regulatory climate that kind of has different regulatory agencies sort of even for surgeons, starting to creep into the way the way you document an operative case, for example. And some of that, there's good reasons to do it. Some of it is, some of it's artificial problems in our mind. For us, it's
more work.
Yes, hoops to jump through, things like that. But if you were to get me on that side, I could, probably spend the rest of the podcast talking about that kind of thing. But there's really not something else that I would rather do, and I think that it's not for me, to tell that person, and sort of. I think it's unfortunate, I think, that some physicians will focus on that negative side.
Mm-hmm.
I think that, what we do is fun. It's
you clearly enjoy it. You love it.
Sometimes it's tough.
Right.
I'd love for us to be able to have this podcast in the operating room so you could see what I do. We love to show people what we do.
I think that's amazing. I really do. And then you clearly love what you do. I mean,
I have students all the time that will. People that will get in touch with me, either they're a family friend, or something like that, and they'll get in touch with me and ask to shadow, and depending upon their age and what they're working on, sometimes they're allowed into the operating room.
That's nice.
I think it gives them a good idea of what's going on, and our job, I think, is to have frank conversations with them, and sometimes that includes some of the things that are less fun about what we do, but those are sort of. We don't like talking about numbers, and we don't like talking about the law and things like that. But they're sort of a necessary part of making those things work.
So, if you were telling someone that, you would say, "Look, if you really love it, right? If you love science, if you love the human body, the anatomy, if you like that, then by all means go."
Yes, absolutely.
Regardless of all the other cloud, right? There's a bright spot there somewhere.
So I will tell you that when we are in the operating room, and I think a lot of surgeons feel this way.
Is there wait? Let me ask you: is there TVs in the operating room, and y'all watching movies? I mean, you hear all these crazy things. I mean, they got music like Van Halen playing in the background while everyone's cutting and dancing. I mean, is it really like that, or is it Is
So I
that
don't
a
know
little
about
bit
the dancing
overplayed?
so much, but there's certainly music in the operating room.
I mean, are you playing like Metallica, like Enter Sandman? Are you like,
So I
or is it more
don't.
classical, calm music?
So for me, it's dealer's choice. So whoever's operating the music device,
You have a
gets to
DJ.
pick.
I'm kidding. I think you have a DJ.
So yeah, they have a circulating nurse in the room who's usually in charge of the music.
But I can see how that would help. I mean, if you're in there for hours, it would be nice to have something to kind of break that, and allow for mental focus.
So I think that if it's a case where everybody knows what they're doing, it is an elective case. It's not something that's distracting in that setting.
Sure.
But you can imagine that in trauma, maybe we did it a little less.
Right.
Or if there's a difficult portion of the case, sometimes there's a part of the case where, music gets turned down or off, and
Right.
you kind of make sure everybody's paying attention.
Sure. And
I like the fact that you like to bring in people and show them around and really give them a chance to see what it's like. Given if it's appropriate, to see what it's like being a surgeon. I mean, what a tremendous opportunity.
I think that most surgeons at the end of the day, despite any complaints anyone might have, they will tell you that when they're in the operating room,
Yeah.
even if the case is not a fun one, maybe it's a tough case, or maybe there's a patient who you just know going in is not going to have a good outcome, but surgery is sort of your
Best.
least bad option.
Right.
Regardless, I think that when they're in the operating room, I don't think they're thinking about much else, and there's a certain piece about that.
That's really good.
So we have a rule in the show that every physician that comes on, we have to ask them their COVID story and how they did professionally, how things changed for the better or the worse. So if you could just tell us a little bit of how your practice changed, anything you went through that you'd like to share, and just anything you'd like to talk on that, because I think I'm tired of talking about it, particularly, but I think some people still like to hear different areas, how practice has changed and things you had to go through, and that kind of thing.
I kind of agree that it's an interesting question, in as much as it sort of put its hands, it affected everyone. It touched everything. It touched every specialty, and every specialty in a different way. And it's interesting to see how people sort of addressed the same problem from their vantage point. For us, it was kind of interesting. There was a period where they shut down elective surgeries. There was some conversations about how to manage these patients, especially in that first wave in March of 2020. We went from no COVID cases to, this huge jump the day that the tests became available. And there was it seemed like an endless line of patients coming in. And for us, everybody was asking for dialysis access because everybody's kidneys were failing, and the other one that was a common question was tracheostomies. For patients who couldn't get off the ventilator but had been stabilized and they had made it through that acute inflammatory phase. And there was all kinds of conversations about when's the right time to do it. Sometimes operating on people that had COVID in a setting, it sort of limits your ability to really protect everyone in the room.
That must have been really hard. I mean, going from universal precautions, right, on like a surgery like you would do now or before COVID, right, to having to do surgery with COVID of a COVID positive patient. That must have been tenfold.
It was interesting. I think that
You had the spacesuit on? Did you have the helmet and all that?
there was a period where we had done that for some of the tracheostomies that were bedside tracheostomies.
Oh, wow.
We had done that. The facility had to, they converted one of the cardiology floors into a second ICU because they didn't have enough ICU beds at the time. I had a wife at home who was pregnant, and
That's scary.
and those were actually, the patients that were hit pretty hard with it. Was, COVID, especially in that first wave, was ruthless
I know from our standpoint, because my wife's a physician too. We had a total infection protocol at our house where we were literally, when you came in, you totally undressed in the garage, put it in bags, immediately go to the shower and throw them in the wash in hot water only. I mean, we did that for months.
We definitely had a version of that, yes.
I mean, and my wife would come home and and I would see her. I said, "Did you get the clothes in the bag?" And then in the washer, did you shower yet? And I was a little high. Look, I'm glad Rory's laughing. I was high. It was a little high drama in our house. I mean, I can't even imagine in surgery. It must have been 10 times worse. I mean,
well, and one of the things is, in the beginning, some of the ways to approach COVID were pretty clear. They started becoming less clear as COVID started to drag on, and maybe you had fewer sick patients in the hospital. And at what point did you resume normal? That was not as obvious a transition on when to resume normal operations and things like that. And so, it was a period where, the CMOs of the hospitals really earned their keep because they had a lot of tough decisions to make. I think that in our world, there were definitely some bad outcomes that I can think of that were sort of tied to that. I think that, there were patients who maybe had abdominal pain but wouldn't come to an ER because they were scared that the ER was just full of COVID patients, which was often true.
Right.
And so, maybe they ended up coming a few days after that with a perforated appendicitis. And so they were much sicker than they would have been previously.
Oh, no.
So there was it definitely affected patients, in other ways.
Is there anything that you or your hospital has put into place or kept in place, I guess, that went into place for COVID that you've kept or that you like? As far as, procedures, are you still asking patients to wear masks? What does that look like? Has it changed your practice, I guess is a better way to put it?
I can't think of anything other than I think that it's been sort of a mass education event, and everybody in the hospital, that maybe didn't know how to wear an N95 mask knows how to wear it now. But I can't think of a lot that's stayed with us as a result, and I'm sure that, when I walk out of here, I'll think of something. But
you can be, aha. Well, let me ask you this. So I watched the Jetsons. Yeah, I admit it. When I was a kid, right? And I heard you talked about a few years ago where Da Vinci started coming in. So I'm going to ask you this. As a general surgeon, you're talking to other surgeons all over the place. Where do you see surgery in 5 years from now, 10 years from now? Is it all robotics? Is there new robots? Is there new techniques? In other words, am I going to be like Captain Kirk on Star Trek and I'm going to go see Bones and he's going to scan me with some little tricorder and give me a pill and I'm going to solely be fine? I mean, that's not realistic. But I'm asking you, do you see anything in the future for surgery or, what's it going to be like in 5 years with advanced things? And are you seeing anything like that now?
So, talking about general surgeons specifically, I would say that I think that there will be improvements on the current robotics platforms. So, instruments that can get in through tighter spaces. Currently, the robot system we use, we generally use 3 or 4 8mm ports. Mm-hmm. So you have 8mm incision sites that you access the abdomen through. I'm fairly certain that they have in the works a single site robot which will allow you to get all those instruments through the same port.
But one port?
Yes, and through a smaller port.
That's amazing.
And, I mean, it's possible that I've missed something here and that's already out, but I don't think it is. And I think that might change a little bit of what we do as they improve that. I think that in more broadly speaking, really the sky's the limit. There's really a lot of things, If I'm not mistaken, the first use of robotic instruments was maybe like in the 80s, I want to say that they used a robot to assist with a brain biopsy.
Oh, wow.
It might have been into the 90s, but don't quote me on that. And they find uses for it. A lot of times they'll have the technology and they'll kind of know that it can be used somewhere. And when I was a resident and they had the robot, I was a little bit skeptical of it because I don't think the technology was really there for it. And I think that they were trying to apply it maybe to the wrong surgeries. And eventually, through that collaboration that we sort of touched on earlier between industry and the rep and the physicians, they sort of find a better way between the two of them on how to apply that technology. And there's really a lot of things out there. Now they're doing the robotic joints. I know they do a lot of those over at Turo.
And I saw one. I saw one where they fed this cable. Like, I don't know if it was from the cath lab or not, but it was some way they don't do stents. In other words, this little device would be fed up through your leg, and it would go up to where your heart was, and it would take it had like a little scooper. So it's like a little shovel, and as it would move forward, it would scoop up the plaque, and it would suck it down the wire, and I'm like, and there was no stent. And I'm like, man, that looks, I don't know if it was real or not. I don't know if I saw it on, one of these, device ads. And I'm like, that's really cool. And that's just one thing. And I'm thinking to myself, there's got to be hundreds of things these people are doing. And I can't even imagine what it's going to look like 5 years from now, 10 years from now.
No, I think that, and this is why I think that collaboration is important, because there's a lot of technology out there, and there's really no other way to deploy it that I can fathom, that doesn't involve reps from the company that are around to make sure that questions are answered. And, you really don't want your surgeon or, whatever the specialty may be, sort of trying to figure out a hardware, while they're in the operating room.
Well, I hope, you're going to be around for quite some time. I mean, you're going to get, hopefully in 10 years, I might need surgery. I'm going to call you up, and you're going to have some device you could, cure everything. And with like knowing like a little incision, maybe it's 2 millimeter. I don't know. Well, that's good. I mean, Rory, I think I got a really good picture. This is really, you do a lot of tough work, Aries. I mean, you got a lot of stress, but you seem to love it. You're on top of things. Every time I see you, you're always happy. Like he's always smiling. He's always happy. And I'm like, man, I wish I want to be like, I don't know how to get rid of stress.
Just go to med school.
Yeah, sure. I'm going to go to med school, right? And go for a 5-year general surgery residency. Gee, wow. I'll be 70 when I get out, right? Well, I want to tell you, thank you. Let me ask you this. We never ask a guest this. Do you have any questions for the healthcare? We can give legal advice, but is on the other side, when you listen to the healthcare side, when you listen to us, are there any things that you as a surgeon or you as a physician walk out and say, sometimes I wish I would have asked the lawyers this. Is there anything that comes to mind, aside from our fees? Because we know y'all love to pay legal fees.
I think. So I don't have any specific questions at the moment, but I will say that I do listen to your podcast, and I think that it's really I think it's really an asset for physicians to really understand the legal framework that they're working in. I think that for physicians, from our perspective, we understand the medical framework very well, but it's worthwhile understanding the legal framework, because if you're not involved in it, like Dr. Quo, who was 2 podcasts ago.
Yes.
If you're not involved in it, there are other people out there that are creating that legal framework for you, and that legal framework will affect the medical framework. It'll affect what you'll be able to do and what you'll be able to accomplish. And so this really is an asset. This really is an asset to us. And, I think that physicians really need to get more comfortable with their attorney friends.
I would totally agree with that. I mean, I think a lot of them see us as like what's it, the enemy, or just sort of a, how would you describe it? Well, I don't know the enemy, but it would be like a necessary evil.
I don't think it's the enemy. I think that what I hear more of is, that we're slowing things down for doctors. That, and I want to say we, I mean like attorneys or legislators or the government, as a broad phrase. We hear a lot that you're slowing down medicine, you're making all these rules and regulations on how we have to document, and we can't do this, but we can do that, and you're going to pay us less, but you want us to see more patients. And that's the feedback that I think I hear a lot, is why is medicine so regulated? Why can't I send a patient to a surgery center that I own without telling them that I own it? Why can't I pay this person, for referring somebody to me? That's what I hear a lot, is explaining to them why we have these regulations, because it's the most heavily regulated industry, maybe above finance, maybe above the financial sector. If not, it's one or two. So I think that's what I hear the most, and it's just kind of educating them. Well, here's where these came into place, and here was the thought back then when
we're here to help.
Yeah, when Stark became a thing, there were issues. Now it's totally evolved into something that Peter Stark did not want this to be, but it is. So I think it's just talking about, where.
Well, I think as to Dr. Christakis' point, reimbursements are going down, tuition's going up. Physicians are looking for ancillary revenue sources that can help maintain or grow just their current standard of revenue. And there's a lot of regulatory oversight with respect to how that is structured properly to be able to do that. And I know that there's a lot of confusion out there. Sometimes, we hear, well, the other guy's doing it, so why can't we do it, right? How many times have you heard that?
Right.
So.
So, one thing I'll say about that is that I think physician burnout is a big topic. And
that's a big deal.
You could, if you did a Google search, you'd find a couple dozen newspaper articles where they're talking about that. And, in my experience, the burnout is not because of the medicine. It's because of everything else. Yeah, I don't know a lot of physicians who are just burnt out just for the, treating patients and doing that. I think that what burns them out is everything else that goes along with it. And so I think that when physicians sort of put that section out of mind, and they put the legal framework out of mind, they're sort of, they end up being bystanders, and they don't get to, they don't get to affect the environment that they operate in, so they really kind of need to listen.
Well, we hope they do. Don't you, Rory?
Yeah, absolutely. Absolutely.
Well, Dr. Christakis, thank you so much for coming on the show today.
Yes,
we really appreciate that. It's been fun. I thought I knew you before, but it's nice to be able to delve in and really see what goes on in your world. I don't know how you do it, frankly. It's tough, being a surgeon, the pressure, but you carry it like a sword. You're doing great. Calm, cool, and collective. If I ever need surgery, I definitely want to come to see you.
Right.
I would feel so much better when he walked out the door. I'm like, man, I'm in good hands,
So I will just say that I think that this is something that's, I think that this is something typical of physicians out there. Physicians are, there's a lot of physicians out there that are just comfortable with what they do. So it's common. But
you're definitely one of them. You're definitely one of those.
Thank you guys for having me. It was a lot of fun.
Yeah, thank you.
We really appreciate that. Well, that's going to wrap it up for us here at Health Law Talk. We really appreciate Dr. Christakis, and it was very, very nice. And we're going to get this out, and everybody can listen to it really soon. We look forward to the next episode of Health Law Talk. Everybody have a great weekend. See you soon.
Thanks for listening to this episode of Health Law Talk, presented by Shahardy Sherman Williams. Please be sure to subscribe to our channel, make sure to give us that 5-star rating, and share with your friends. Shahardy Sherman Williams is providing this podcast as a public service. This podcast is for educational purposes only. This podcast does not constitute legal advice, nor does this podcast establish an attorney-client relationship. Reference to any specific product or entity does not count as an endorsement or recommendation by Shahardy Sherman Williams. The views expressed by guests on the show are their own, and their appearance does not imply an endorsement of them or their entity that they represent. Remember, please consult an attorney for your specific legal issues.